So please go ahead with your second talk.
Oh, I think Arthur's next? Okay, we can continue with the other one then, the first talk, and then we don't have to switch. So the next talk is going to be about aqueous humor outflow imaging, which is an area that I do a lot of work with. In particular, here we're going to be talking about medical and surgical care. But here at APO, here at AIOS, there's also an important emphasis that has to be made, is that this is also a talk about the contribution of Indian ophthalmologists, clinicians, and scientists, because as you will see, they have actually added a lot to this work. Here are my financial disclosures and my sources of research support. So, when we typically teach outflow, we start with a two-dimensional picture like this on the left, but we have three-dimensional eyes. So the problem is that this is essentially implying to our students that outflow is 360 uniform or even. But there was always evidence that outflow could be segmental. There are areas of good and bad, here depicted in green and red arrows. Then that could create patterns. And so the outflow patterns then could be different between me or you, or between your left eye and your right eye. And then there may be, sorry about that. I pushed end on accident. Let's go back to the top. The end button is very close to the next button, actually. Okay, there. Disease relevance, or the high pressure part of glaucoma, may come from the loss of these good regions. And so a number of years ago, we wanted to develop aqueous humor outflow imaging. We called it aqueous angiography. I'm going to skip through all the laboratory stuff and get straight to patients. On the right-hand side, you've got a 65-year-old Chinese woman. Indocyanine green is in the eye, and you can see there's pulsatile flow pulsing through right there. It's segmental because it's only in one location, and it's dynamic because actually it's going to start to grow. Now, because this is cataract surgery, we can ask her, I want you to look up. So she will look up, and then you'll see this area very bright, and then, it's starting to go away. So again, it's dynamic. Then she's going to reset her eye, and superior nasal, there's going to be another region where there's pulsatile outflow. So the outflow is pulsatile, it's segmental, and it's dynamic because the region down here is actually starting to grow back. We started imaging more patients using ICG and fluorescein, kind of copying retinal angiography. During cataract surgery, these are all normal patients, okay? Every row is a normal person. You can see most of the outflow is nasal, like the MIGS literature suggests. Superior, inferior, variable. Temporal typically has the least, but in some cases, temporal actually can have the most. This is something we'll talk about later. Usually it's the least. We also started to do sequential, meaning 2 dyes in one patient, back to back. So ICG first, fluorescein second. You can see that the patterns are very similar. That's the point. The molecules are different, so the imaging should be a little bit different, but mostly it's similar, and what that creates is an experimental system, because then you can use one tracer, get the background, then do something like a surgery or add a drug, and then add the second tracer and see what the effect is. So from that point, we wanted to think about disease, and this is where we started doing a lot of work here in India with Dr. Shikha Gupta from AIMS. I point out that for this work, she won the Arvo-Roche Collaborative International Fellowship Award in 2021 to support this. She started doing angiography in adult Indians. During cataract surgery, it looks very normal. But then we also started looking at childhood glaucoma. And why did we do that? Because in childhood glaucoma, pressure very high, right? It's not just like 22, but 30 and 40. And what we see is that there are still pathways, but the branching, the small branches is what's gone. So we started to quantitate this, right, and looking at the branch patterns and so forth. And what we found comparing pediatric glaucoma to adult cataracts is that the average branch or the maximum branch length is very similar, but the total branching is suppressed. And that reminds me of when we were all in college doing electrical analysis in physics with circuits. Remember, branches are resistors in parallel. More branches is less resistance. Fewer branches is more resistance. Fewer branches is higher IOP. So this is like an example of now why in pediatric cases, pressure can be higher for a distal cause, and maybe why it continues to be high even if the trabecular meshwork's open. So I'm going to talk now about drugs and then slowly transition to surgery, because we can use these tools to interrogate this. This is work done with Dan Stamer at Duke, one of Sanjay's partners on the investigative side. He's a PhD scientist. In their perfusion system, they can get a baseline outflow facility, stable. They add a little endothelin-1 to give a little bit constriction so that the tissue, this is postmortem, is a little bit constricted. And then they start adding nitric oxide donors, namely DTA-NO in the red or nothing in the black. As many of you know, there are nitric oxide donor glaucoma medicines like Vyzulta, which can lower IOP, presumably through some relaxing of vessels and pathways. And so you can see that with a nitric oxide donor, the facility goes up. Now we can look at what happens structurally. If you perform the angiography on these vessels, you see the aqueous veins. Separately in another location, you can see the collector channel. You put the endothelin vasoconstrictor on, it constricts. You put the nitric oxide derivative back, the vessels open up again. So, this is a tool to study what's going on with drugs. In fact, we took another step further. So this is work by Chris Gerken, used to be the chairman at Alabama, now is my partner at UC San Diego, he moved over. These are subjects where we were using Myocol. In the US, we use Myocol to constrict the pupil for cataract surgery. I understand you guys have pilocarpine, intracameral, same concept, okay? ICG goes into the eye first, like for instance here. Then we either add Myocol or BSS because these drugs lower IOP, should increase outflow. And then what we see in the yellow areas, in cases with Myocol, we see that there's actually improvement. These 1-2 becomes 1-2-3. Now, this isn't that surprising because you're going to say, well, these drugs are supposed to lower IOP, so outflow should be better. But here's the problem. The drug is everywhere. So how come it only rescues in focal locations? What this is telling us is that there's something special about these spots. They are rescuable. And there's some feature that allows them to be responsive to the drug. These may be the features that are lost in glaucoma. These may be the features that we have to now understand to basically treat high pressure in the future. And so really this model is generating a lot of hypotheses for us. So then to surgery. In the setting of segmental outflow, it's been debated, where should surgery be performed? Should we do trabecular MIGS in areas where flow is good because we know we have a pathway to access? Or should we do surgery where flow is bad to give ourselves the opportunity to improve it? So we started first in the laboratory. Again, 2 tracers, ICG goes first, fluorescein goes second, no surgery, this is just a control, very similar. Here's an eye where ICG goes first. We see a low flow region. We open the eye, put an eye stent right there, run the fluorescein, and you can see that with surgery, the outflow pattern can be rescued. On histology, full thickness bypass. These are postmortem eyes, so look at these tiny dots. Tiny dots are just debris in the anterior chamber. You can see the tiny dots is flowing into the eye stent that is right here. So with surgery in the laboratory, we can change these patterns. But what about in patients? So this is a collaboration with Glaukos as well as Heidelberg Engineering that we performed in Armenia. Left is ICG before, right is fluorescein after. The 2 red arrows are eye stent placement. We were very careful to time everything up. And so this is really the result of trabecular bypass within an OR setting, immediately after surgery, what you're trying to improve. Here, what you have in that same study is an individual with glaucoma, 2 low flow regions. We found that. We put 2 eye stents right here, run the fluorescein, we can rescue it back. That's one type of improvement. But we actually saw other things as well. Here's one eye. ICG goes into an eye, low flow region. We put 1 surgery right there, run the fluorescein. Okay, same thing. But remember, everyone gets 2 eye stents because that's what's on label. So then the second eye stent was already placed near an area, had baseline flow. So now when we run the fluorescein, we don't see new pattern. We just see the same pattern. It shows up earlier. So it's kind of like 2 types of improvements. And then we were left with, well, what does that mean? What does that mean for the OCT? This study was very hard to do that because we only had 14 patients, and many patients like this had 1 stent in low, 1 stent in high. How are you going to tell the difference? So we knew we had to take a step back and go back to the laboratory. And so this is Dr. Clemens Strohmeyer, who's an associate professor from Johannes Kepler in Linz. And what he did was he melded together the angiographic system with perfusion system to measure facility. So here's the experiment. We're back in the lab now. You get an eye, you get the outflow facility. Then he performs the angiography. Here's high flow, here's low flow. And then he does a goniotomy in high flow or low flow, and then he checks the facility again. And so here we have pig eyes and human eyes, and you see at baseline facility is stable. When we do the trabecular surgery, the ablation here, facility always goes up, aka resistance goes down, but the low flow surgery location is so much better. Here's data on box and whisker plots. If surgery is in a low flow region, you get greater increase in facility, greater decrease in IOP. So this became the first quantitative clue that targeted surgery could make a difference. But you know what? This is in the laboratory, postmortemized, preclinical model, right? So then what about patients then? The problem with patients is that, angiography is expensive, invasive, and takes time. How are you going to find a low flow region? Well, most people are actually low flow temporal, usually. And so this led to work by Tanujata here in India, where he was also performing this angiography with bettanino goniectomy bangs. Here's an eye, ICG goes first, temporal nothing. He puts the ICG in, TM looks nice, he does the bang, and he actually rescues temporally. This is very similar to my Armenia data, except that we were there in the nasal part of the eye. He's here temporal, showing that temporal can be rescued. And then this then led to this clinical study, an early pilot study, 30 patients, 15 surgery nasal high flow, 15 surgery temporal low flow, and then what happens over time. Okay, IOP goes down because they had surgery, but we really don't see a difference between high flow, low flow. Well, this is a pilot study. Everyone has drops. There's no IOP with a washout measurement, single measures. This was just a quick look. So then if we redefine the endpoint as success being 20% reduction with or without drops, then we start to see a little bit in terms of a difference between, in patients now, surgery low flow, maybe a little bit better. But of course, this study has to be done in a more rigorous fashion, more patients, drop, washout, real holiday IOP measurements, and maybe multiple measurements through the day. I will point out that it was this work that was put together that yesterday was awarded the 2024 Best of the Indian Journal of Ophthalmology Glaucoma Review by this team with Dr. Tanujata, and Nitika Berry is also right here, part of this team as well. So one more thing. Everything I've done up to this point has always been imaging, doing something, and imaging at the same OT visit. What about over time? People say, what happens if you go home and you get re-imaged later? The problem in adults is that there's no reason to come back to the OR. It's invasive, right? That's the issue. But this is where we worked again with Shikhar Gupta, because we're dealing with kids who get repeat examinations normally for just evaluation, removing surgeries, or additional sutures. So here are some kids with baseline childhood glaucoma, not a lot of signal. They all got GAT. And then 1 to 2 months later, on repeat evaluation, they got a second angiography, now showing for the first time over time there can be sustained improvement. All right? So this is the first time we've ever looked over time. Shika was supported by the American Glaucoma Society for this with the 2024 Alan Crandall International Humanitarian Award. Also, this was just accepted this week into ophthalmology glaucoma. So in conclusion, multiple species, multiple tracers, enucleated in live eyes. Trabecular outflow is segmental. TM surgeries and drugs can influence those patterns. It may be that targeting low flow is better. It may be that doing surgery on the temporal side of the eye is an easy way to get to low flow. But I will say that the thing I do know for sure is that working with my Indian colleagues here, the Indian ophthalmologists and Indian scientists, has been a real benefit to myself, a real pleasure for me to learn a lot from them. And so thank you very much for being here.
Yeah. Dr. Alex, I think that's a very wonderful paper. So as a corollary, do you advocate doing aqueous angiography before undertaking mixed procedure, number one? And number two, after that, like in the recommendation you said, it has to be repeated months after the surgery. So that regular angiography needs to be done, say, once a year or twice a year after you do this?
Impossible. We developed this. It's too expensive, too invasive, it's too difficult. I kind of think about this as the gold standard for what's going on. But for widespread application, it's almost unreasonable. So then what is the next solution to take the next step? And it's a little bit of like what Dr. Asrani said for the posterior segment and what the title of the session is, which is structure and function, right? Function here is going to be flow. Structure could be then OCT again. So the way I see it is that we use the flow information to get what really is going on and what we really should be doing, but then it has to be reinterpreted as structure only. That structure function has to be put together. That's why we had the outflow specific AIOS-OCT, We're going to try to take the flow information and then make it a matter of what the structure is that determines those flow patterns. And then we can all do ASOCT before surgery, because that's reasonable. And follow up with ASOCT as well. To really do the angiography by itself, I think routinely is very difficult.
And when do you think that it will come into the clinical practice for the missions of most of the ophthalmologists?
I think it's going to be
How,
tough.
what is the time frame that you're looking at?
Well, my time frame is to try to actually convert this to structure. But let's use an example, a real-world example. Intravenous fluorescein angiography for retinovascular disease, right, was invented in the 1950s, 1960s. And it took our retina colleagues 40 years, 30 years, 1980, 1990, to make it the routine process that today is so easy. Everyone can do it quickly, right? It took them many decades. For this was all developed in 2015. So if we were to do the same concept, maybe we can make it easy in 20 years. But before then, what I'm hoping for is to really use this information to then help guide us to structural endpoints, to make it more practical. Otherwise, I mean, we have to have a lot of innovation to make this easier.
So would you be doing it before MIGS surgery in all your cases?
It's
Just
for
to-
research. Well, we're doing it to help us figure out where to place the surgery,
Yeah.
but it's not like something that I'm recommending that everyone do, because anyways, most people cannot.
Cannot.
Yeah. I mean, the one thing that might come along is, we're developing, not we, but many companies are developing new surgical microscopes, right? And so then the question is, can they implement some of this technology, build it into the scope? And then clinicians can start adding the tracers and take a quick picture. That may be one solution, but it's also convincing them to actually do that. They're struggling as is to get the OCT in the scope.
Yeah.
Thank you, sir. Thank you, Alex, for highlighting the latest that